Thank you all for being here. Thank you so much to everyone at HRSA for convening us. These clearly are challenging problems for all of us in northern New England and really across the country. What I thought I'd do this morning is give a fairly broad overview of the roles that all healthcare providers and healthcare staff can really have in helping patients who are challenged with substance use disorders. I'm going to focus mostly on opioids, but I'm going to mention other substances as well. If there is any positive, and there, with all the loss of life that we experienced, we can't call it a positive, but if there's anything that comes out of this epidemic, and I agree at this point it has become an epidemic across the country, is that for decades, really centuries, the mental health and substance use system in our country has been really segregated from general health care. And as we understand these problems more, we know that addiction is a chronic disease. Mental health disorders are chronic conditions, and we need to treat them very much the same way, different emphasis in our care, but very much the same way as we treat diabetes, asthma, hypertension, and others. So all of us in healthcare, not just psychiatrists and addiction medicine specialists, need to really be comfortable evaluating and addressing these disorders and dealing with some of the distresses that present to us from patients who are affected. So, with that, I'm going to go very quickly through a lot of different topics. I hope to leave some time at the end. I believe I have an hour, some time at the end for some discussion. So I will go through and we can talk as we go. Whoops, sorry, disclosure, I have no commercial relationships to disclose. I have two employers, Dartmouth-Hitchcock System and Silver Hill Hospital. So what I will do is start with a bit of history related to opioids and some other substances, and a little bit about pain treatment too, because as we know, pain treatment has been interwoven with the increase in opioid availability and some of the challenges we're seeing, and look at some of the data of where we currently are. Then I want to talk about substance use disorders as chronic conditions, and then focus on our roles in reducing opioid and other substance-related harm. So, oops, my clicker is not forwarding me. Let me try a different button. I think there's some people in the booth. It worked for the first two slides. There we go. Okay, so opioids have been around from literally millennia, at least 5,000 years. Our earliest recording of the opioid was a picture of Papaver somniferum, the opium poppy, on a Sumerian cave wall with the words Hul-Gil, meaning the joy plant. So that portended a lot that we know about opioids, that they can be used for harm, they can be used for pleasure or healing. Throughout, whoops, it's just my touch. I have to learn my touch. Okay, throughout medical history, they have been up and down in favor, with one generation embracing them and the next seeming to run as fast as they can from the use of opioids. So in the mid-1600s, Thomas Sydenham, who was one of the founding fathers of Western medicine, a British physician, said, among the remedies it pleased Almighty God to give man to relieve his suffering, none is so beneficent nor efficacious as opium. And he went on to say that he'd cease the practice of medicine if it weren't for opioid, because there was nothing more he had to offer patients. And yet, about 3 centuries later, at the beginning of the 1900s, John Witherspoon stood before the AMA and in a lecture entitled A Protest Against Some of the Evils in the Profession of Medicine, said, we must save our people from the clutches of this hydra-headed monster, meaning opioids, that stalks the civilized world, wrecking lives and happy homes, filling our jails and lunatic asylums. So two physicians with very different perspectives on opioids. And we see that even today. As late as the 1940s, this statement in the JAMA, the use of narcotics in the terminal cancer patient is to be condemned due to undesirable side effects. Dominant in the list of these is addiction. So I want to go over a little more of the recent history just to see, I think history informs where we are, and we don't want to repeat ourselves going forward. So I think it's helpful to understand a bit about it. So in the late 1800s, the early 1900s, post-Civil War era, opioids were widely available. We didn't have a lot of pharmaceuticals to treat pain or for anesthesia, but we did have a lot of naturally occurring substances. Opioids, willow bark, from which aspirin is derived, cannabis, which was used and until 1942 was part of our pharmacopoeia in the U.S., cocaine for numbing, and alcohol certainly was used a lot for surgical procedures. And opioid prescribing was widespread. There were no restrictions on it, and there were no restrictions on selling or buying opioids in the street at that period of time until the Harrison Act in 1914. Which began to track and tax opioids as they were imported or transferred from importation to pharmacies, to patients, or to the other sources. So we had a little more control over the opioids. Then in 1919 and 1920, there were two decisions in agencies within the federal government that ruled in the context of people being treated with opioids for addiction, because in that era, physicians, if somebody became addicted to opioids, they could simply give them opioids to prevent withdrawal, to prevent craving, and try and find a balance in quality of life. But the federal government ruled that addiction was outside the realm of medical interest. It was something other than a disease, and we began to get this carve-out of treatment of addiction from treatment of other chronic illnesses. So opioids continued to be legal for treatment of pain, but they were illegal for treatment of the disease of addiction. And so there was this kind of dichotomy. If you know that you use opioids, and some patients may develop challenges with them, become addicted to them, people backed off from using opioids. And also because there was, at that time, it was estimated that up to 1 in 70 Americans were dependent on opioids or addicted to opioids. I want to just mention that cannabis was legal in the States, and it actually wasn't a pharmacopoeia. It could be bought through through pharmacies until 1942. There was sort of, in the 2 decades before that, there was increasing restriction, and finally it was taken off and became the pharmacopoeia and became illegal for medical use at that time. And I'm going to talk a little about cannabis as we go through. My slides here are not the same. If you have a handout, they've been changed a bit, but they follow kind of along. So in the 1950s, I don't know how many of you were around. I was a little girl in the 1950s, and I remember how frightened people were of cancer at that point in time, because cancer was not aggressive. If somebody had painful, progressive, terminal disease, the pain wasn't treated very aggressively. In most cases, there were some physicians who would treat it aggressively, but in general, people were terrified of having painful illnesses, such as some forms of cancers. People would defer elective surgeries. They'd say, I don't think I can stand the postoperative pain. I'll just live with it, until whatever needed elective surgery was worse than they anticipated postoperative pain would be. And people with chronic pain rarely had the option for opioids. So if other things weren't effective, they lived with their pain. Things changed a lot in the 1960s. There was a huge cultural revolution, I think, and our attitudes towards drugs and pharmaceuticals changed quite a bit then. Methadone treatment was introduced by some researchers at Rockefeller University, and they negotiated with the government on prescribed settings to develop clinics where persons with opioid addiction could be treated using methadone. I'll talk about methadone treatment a little later. And the American Medical Society on Alcoholism, which later became the American Society of Addiction Medicine, which is flourishing now, was founded in the 1960s. The Haight-Ashbury Free Clinic was one of the first community health centers in the country, and they were in San Francisco at a time when there was a lot of drug use, and some people became addicted and developed disease and harm associated with drug use. And they would take people in and model this treatment of people with the disease of addiction respectfully and as a medical condition. So they were really pioneers in this area. At the same time, pain treatment was changing. We didn't treat pain very aggressively. We certainly didn't use opioids in the 30s, 40s, and 50s very aggressively. But in England at St. Christopher's Hospice, they pioneered the Brompton's cocktail and really demonstrated using a combination of heroin, alcohol, cocaine, and Thorazine to keep you from vomiting, and variations on that with all those drugs, that people actually could have pain relieved in severe terminal illness and die with dignity and being engaged in their lives. So that rapidly spread in the 70s, I think, to this country, and hospice and palliative care became a profession within medicine. The International Association for the Study of Pain was founded, and pain medicine became a specialty within medicine. So we have the rise of addiction medicine, the rise of pain medicine. In the 70s, we still had payment for interdisciplinary care when somebody had chronic pain. So exercise, meditation, relaxation, cognitive behavioral therapy was used at that time. We're seeing a return to these multidimensional approaches to pain, in part, I think, because of the rise in opioid addiction associated with chronic pain treatment with opioids. But back then, it was routine. That's how chronic pain was treated, and quite effectively. But, in the 1980s, that changed in interdisciplinary care. We had changing business models in the field of medicine, and there was less of that. There was also the observation in the 1980s that while we were using opioids for cancer pain and we began using it for post-operative pain, at Sloan Kettering the observation was made that some people would come who didn't have cancer pain but had severe chronic pain, and if they used opioids as they did with cancer patients, some of the patients actually did very well. And there was a fairly well-known case series published in a medical journal suggesting that opioids, patients with chronic pain did not inevitably become addicted, they didn't inevitably become tolerant, and looking for tools to better treat people with pain, our society really embraced the use of opioids. At the same time, as we moved into the 90s, there were new pharmaceutical products, long-acting oxycodone, long-acting morphine, and the expectation was that with fewer ups and downs of medications, patients would get better pain control, and perhaps there would be less reward and less problems with addiction. I think what wasn't anticipated at that time is that those medications can be adulterated and made, now we're getting tamper-resistant medications on the market, but that patients could chew them or alter the form and inject them, and that when we have these sustained-release opioids in a very concentrated form with lots of milligrams, a little tiny pill can give a much more bang for the buck than Percocet mixed with acetaminophen. So we saw the misuse and the rise of misuse of opioids. And the use of opioids was actually probably supported and encouraged by pain treatment becoming a quality measure in hospitals and in clinics. So opioid therapy of all pain increased. We also had the concurrent increase in technologies for pain, and there was a sense that we can just get rid of pain if we just are aggressive enough with the opioids, aggressive enough with our technologies. And at the same time, the business of medicine was crescendoing. There were new financial forms, and we saw interdisciplinary pain care going down and quick prescriptions and technologies going up. And unfortunately, this is what we saw. This was published by the CDC in 2011, and it looks at from 1999 to 2009. In the green, you see the increase in prescription opioid sales, and paralleling it in purple, you see opioid-associated deaths, and paralleling that in yellow, we see demand for treatment of opioid addiction. So we are aware that as the availability of opioids for the treatment of pain increases, we've had these parallel increases in deaths and in demand for treatment of opioid addiction. So in the early 2000s, the industry really switched from, I think there's still a lot of promotion of opioids, but this whole other industry of risk mitigation grew up, and we see urine drug screening companies and tamper-resistant opioid formulations, and industries really focusing on how to benefit from the problem, but also create solutions to the problem. We've also seen a proliferation of opioid guidelines. I'll go over some of those in a while. And then in the early 2000s, buprenorphine became available for treatment of opioid addiction. So we have a second tool in now naltrexone as well to treat opioid addiction. I'll talk about those later on. There's been a renewed interest in interdisciplinary care of pain, as I mentioned. We've had a lot of healthcare reforms that have expanded access to care so that we can and created some parity between, or at least in theory, and I think in many places there is more access to substance use treatment and mental health treatment. But we've also seen, as opioid prescribing has leveled off somewhat in many states, we've seen a rise in heroin. We've also seen an increase in legal cannabis, I'll mention that a bit, and a really increasing requirements as guidelines for opioid prescribing have increased. We've seen some states adopting real prescriptions, and I think Maine and New Hampshire are among those that have some of the strongest legislated restrictions on opioid prescribing. So just to look a little closer at national opioid overdose deaths, these are the number of deaths between 2002 and 2015 from prescription opioid pain relievers. And we see that they seem to be beginning to level off. We need to be aware of where these are coming from. I mentioned that in parallel with our prescribing, we've seen deaths and treatment going up. The a national survey on drug use and health, which is conducted every few years, has twice looked at where patients who non-medically use opioids say that they get their opioids. So they ask somebody if you've ever used a prescription for a reason other than that intended by your doctor, or have you ever used somebody else's opioid prescription. That's what they define as non-medical use. And then they ask people who identify as having non-medical use, where did you get the opioids that you use non-medically? And most of them, if you look at the red, we see free from a friend or relative, and in the dull red, bought or took from a friend or relative. And that adds up to roughly 70% of people. Another almost 20% say they got them from one doctor. But, so you would, looking at that, 20% get them from a doctor. But when you ask, where did your friend or relative get them? In the white, you see from one doctor. So this suggests that in the course of our prescribing, it is our medications that are being used non-medically by patients. So clearly, there is a connection between prescribing and the availability for misuse, addiction, and association with overdose deaths. But what's happened in the past few years is as opioid deaths related to prescription drugs have leveled off or in some states gone down, what we've seen is a huge rise in illicit opioid deaths from heroin and now fentanyl and carfentanil. So this is 2002 to 2015. When we look at states overall, this is from 2015. You don't want to be in the darker red group, and if we look there, we see Maine, New Hampshire, Massachusetts among the groups with the highest rate of deaths. Now, Maine has not made the top 5, as my state of New Hampshire has, but it is in the top tier of opioid-associated deaths. So there are a lot of people looking at why that is, and I don't think we know fully. And if you looked in 2013, our states were in the middle. What's happened since then, I believe one of the huge contributors is the rise of carfentanil, and that we are on the distribution chain for carfentanil. I'll talk a little more about that in a while. It's a very potent opioid that has led to more deaths. So these are some statistics for Maine, and it's a complicated slide. The original source is from Dr. Sorg at Policy Center at the University of Maine, but this was on your DHHS website. Some of you may have seen it before. I wanted to first draw your attention to the red, and fentanyl is in kind of the the red and the green, which are methadone and oxycodone. So emblematic of prescribed or dispensed medications. And if you look at those, what you see is a trend downward, reflecting reduction in prescription medications. If you look at the purple, you're seeing heroin, which in urine drug screens or in blood toxicology is usually identified as morphine. So you see a rise in the association with heroin, and then in the orange you see fentanyl, beginning in about 2013. So I think how New Hampshire, Maine, and Massachusetts started going up has to do with fentanyl and carfentanil and the rise of heroin. The other thing to look at, though, is that benzodiazepines remain very, very high, and there seems to be an association. Benzodiazepines on their own, as you probably know, it's very difficult to cause a respiratory overdose death with benzodiazepines. But when they are combined with opioids, there seems to be at least an additive effect, possibly a synergistic effect. So that we're seeing, this is again from the DHHS website in Maine, that 1 to 3 of the overdose deaths in Maine are associated with benzodiazepines, and 1 in 4 associated with heroin or other illicit drugs, opioids. Actually, when you add the heroin and the fentanyl, it's clearly more. So opioids are probably number 1, but in combination with benzodiazepines, the main point that I want to make is co-prescribing of those has a lot of risk, particularly if people misuse or overuse them together. Just to acknowledge that we've also seen babies affected, and this is babies born with physiologic dependence on drugs going up and up in this epidemic. It's important to remember, though, that opioids are not our only problem, and if you look at adults, again, this is the TEDS data set. It's treatment episode data system, and all federally funded treatment centers are required to submit the primary drug of dependence when people come in for treatment of substance use disorders, and people name alcohol as number 1 through the first decade, most of the first decade. I couldn't get more recent data for Maine. In New Hampshire, if you see the yellow rising, that's opioids being named as the primary drug. In New Hampshire, opioids have surpassed alcohol, which is really stunning. Alcohol has been our number 1 drug of misuse for centuries. And so opioids are rising, alcohol, and in some cases seem to be substituting. This is a really important slide, though. This is looking at adolescents. Now, blue was alcohol on the other slide. Blue on this slide is marijuana. So cannabis for adolescents remains the number 1 reason for which people seek treatment. Again, you see a dip towards the end. I wasn't able to follow that out and give you more recent data. I don't know if anyone has it, but I know you've recently legalized cannabis in Maine. You've had medical marijuana for a while, and we'll need to follow that very carefully to see how that impacts adolescents. I want to talk just a bit about cannabis. I added something. Why we don't recommend our patients smoke opium. So why do we have people smoking cannabis as a pharmaceutical? There's a very complicated history of policy. We ended up making pharmaceutical drugs from opium before we began to isolate cannabinoids, which are the active constituents of cannabis. And that's really part of it. We haven't had many drugs that we could use that were made from cannabis, and clearly there are some active constituents that may be helpful in healing. But we've also seen a huge pressure from legalization lobbies that have actually used, if you go to the Marijuana Policy Project's website, MPP website, you'll see their strategy, which is nicely laid out and very effective, which is to advocate for medical marijuana in states, and once states have that, then advocate for decriminalization, and once states have that, to advocate for legalization. And the reason that is so effective is because there's a lot of money invested in the startup of cannabis dispensaries and cannabis growing And once the money is invested, it's very hard to turn back from that because there's a lot more advocacy that goes on. So that's one of the reasons. There are also research challenges. We have had a lot of hurdles for people to research any Schedule I drugs, and cannabis has been a Schedule I substance and remains a Schedule I substance, and there have been a lot of other hurdles and research challenges, so we haven't developed those pharmaceuticals. And then there's the therapeutic reality that some patients do benefit from in different ways from cannabis. So, the situation that we have now is, if you look at opioids, we have lots of those, but we really only have 2 cannabinoids that are available through pharmaceutical use. Dronabinol, which is a THC, and THC is the component, it's a very active component of cannabis. It causes the rush and the high and the pleasurable sensations that some people enjoy, and it also may have some effect on pain relief. Nabilone is similarly a THC analog, a synthetic analog. We have a couple of other cannabinoids that are in phase 3 trials in the US. One is Epidiolex, which is a pure CBD cannabidiol, which seems to have some anti-seizure activity and anxiolytic activity. And that's expected to come on the market with a specific indication for certain childhood seizures in the next year or 2 years. It keeps getting pushed out a little more. And then Sativex, which is available in Europe and in Canada, it's a 50-50 mixture of THC and cannabidiol. So in any event, there are pharmaceuticals in the pipelines, but in the meantime, we have herbal cannabis. There are over 100 cannabinoids in herbal cannabis. Those are active constituents that bind to cannabinoid receptors in our bodies, and probably about 500 other, altogether 500 biologically active chemical constituents. It's a very complex herb. I mentioned THC and CBD, but there are many, many others that are cannabinoids that are less studied, but are undergoing study at this time. There are many, many diverse strains, and growers and dispensaries are really working on trying to identify what herbal preparations have what strains, and to try and control that somewhat. But it's important to understand that there's no federal oversight. Many states have tried to have oversight from their departments of health and human services or their substance use departments or others, but few states are really funded very well to regularly check and see what different batches of cannabis have. I don't know how Maine is doing with that. But so for many of our patients, the use of cannabis is pretty imprecise. And there are, according to the National Academy of Science, some evolving evidence of effectiveness of some strains of cannabis in chronic pain. For nausea and vomiting, we have medications associated with chemotherapy, and for HIV cachexia, we have medications, and cannabis may be helpful for that. For the subjective feelings of spasticity and multiple sclerosis, there may be some effects on sleep, and then a number of others for which there is limited evidence. But it's important to recognize that there are many, many neurobehavioral side effects, public health consequences, cognitive changes, perceptual distortions, earlier onset of psychotic illnesses in people at risk, physiologic dependence and withdrawal. 9% of recreational users go on to develop addiction and seek treatment for marijuana dependence, about in par with alcohol. There may be some effects on, there are known to be lower birth rate and pregnancy complications, developmental changes in adolescence, and on and on. So this is not a risk-free drug, and we need to know more to really find the balance. So the list goes on. Few people know about the cardiopulmonary effects. Tachycardia signals the onset of cannabinoid effect, THC effect, and in people at risk for MIs, there have been association of onset of tachycardia causing increased myocardial demand and myocardial infarction. There is a literature on cerebrovascular accidents, on strokes in association with cannabis use. That requires more study. It's not conclusive evidence, but the American Stroke Association has said we need need more research on this because there is an increase in strokes among young people, and there is some suggestion that there's a possible association with cannabis. Not certain yet, but I think it's something, if patients are using cannabis, that they need to be aware of, exacerbation of COPD. And then there are another possible lesser-known side effects. So just a few words on cannabis because it remains with us as an issue. So heroin, we mentioned, has been rising and causing more deaths. It was synthesized in the late 1800s. It was thought to perhaps be a non-addicting morphine, but it turned out to be quicker in onset and probably more associated with misuse and addiction. I mentioned that when we're looking for it in urine drug screens, we're not going to find heroin, but usually morphine. Interestingly, heroin, opioids start their lives either in illegal fields, and here's a picture in Helmand Province of a USGI standing in a field of illegal heroin, or in legal fields. And in Tasmania is probably the biggest grower of legal opioids. And then opium is extracted. And you can see the opium resin here. It's collected, and then heroin is extracted from it, and this looks very similar. In Afghanistan, we have illicit, and Mallinckrodt is a pharmaceutical maker of opioids, and it's collected, and then the opioid is extracted for it. It's time-consuming, it requires growing, it requires several steps. But ultimately, it ends up in the street, and there are marketers who are very professional about their marketing, pitching different names and different brands to different people. What's happened more recently is the rise of fentanyl. And this is not fentanyl that's diverted from pharmaceutical markets. This is fentanyl that is manufactured in plants in China, in Colombia, in Mexico, and other settings. And you can imagine the advantages of that. It doesn't require growing, paying farmers, cultivating fields. Easier to hide the operation. And the advantage for traffickers is it's very small because fentanyl, 100 micrograms of fentanyl, micrograms is equal to 10 milligrams of morphine. So very much more potent. And carfentanil, 1 microgram, fit on a head of a pin, is equal to 10 milligrams of morphine, which is equal to 8 milligrams of heroin. So this can be packaged in very small packages and transported. They're greater risk for users because it's much more potent, and that is associated with the increased deaths that we have been seeing. Okay, so the relationship between opioids and heroin, we know that actually, it says almost 50% of injection heroin users report using prescription opioids prior to heroin. If you interview young people under 26, it's about 75%. So 50 to 75% of heroin users use prescription opioids prior to using heroin. So that would suggest that everybody, that's been taken to mean by some people that there's a very, very high rate of people being exposed to opioids and developing heroin addiction, which there is certainly that risk. But what other studies have shown is that that people who develop addiction to prescription opioids often have a trajectory to the development of addiction. So people with a prior history of substance use disorder, whether it's alcohol, cannabis, or others, are more likely to develop addiction on exposure to opioids. We know that most prescription opioid exposures don't lead to addictions. Tens of thousands of people every day use opioids, and a certain percentage will develop addiction and studies are all over the place on that. One study that looked at many different looked at the best available data, found that about 1 in 500 people with no prior history of SUD, substance use disorder, develop addiction, but in the general population, it's 3 in 100. That's a very high rate to develop a potentially life-threatening disease on exposure. And if you look at people with prior histories of some form of substance use disorder, it's clearly higher than that. We don't have precise numbers. But so we really need to target strategies that identify risk and that provide opioids in manners that keep our patients safe. The concern is that now that heroin and fentanyl are so cheap, so potent, and so available, that more people will begin initiating with that because it doesn't require injection anymore, just snorting or rubbing on gums. So, disease of addiction, that's sort of where we are. Now, a lot of reasons that people use substances. Some people just experiment, they're interested, they're young, they're curious, and they will use them for experimentation, just to see what it's like. Other people want to get high. They just feel like partying or getting high. That's the importance of educating about the relative risks associated with different substances. Because if somebody has a biologic predisposition to addiction and they start experimenting with prescription opioids, very, very high risk. So education on the relative risks associated with these substances. Self-medication of symptoms is very common. Somebody feels anxious and they take a drink, or they want to get high with marijuana, or somebody offers them prescription little oxy to settle them down or perk them up. They may use them to medicate symptoms. So it's really important for us to really screen for symptoms that when patients are substance involved and see if we can find better treatments. Compulsive use to addiction is triggered in some individuals, and then there are people who clearly just engage for profit. So all drugs that patients use to get high, whether it's marijuana, it's opioids, you'll hear about tobacco later on, or for some pleasure. We don't think of tobacco as getting high exactly, but for pleasurable effects. Cocaine and others all the final common denominator is stimulating release of dopamine in the limbic reward system. The limbic reward system is deep in our brain, as you can see, the ventral tegmental area, the nucleus accumbens, and it's a very ancient part of our brain that's necessary for survival. So food, drinking water when you're really thirsty, sex, all act at these pleasure centers. And if you think about it, those are all necessary either to sustain our lives or to sustain our species. So pleasures are very potent. And all these drugs that people use to get high stimulate a similar kind of reward in the limbic system. The feelings associated with different drugs are somewhat different. Cocaine, marijuana, opioids, they're different highs because of other things that are going on in the brain that modulate the reward or the feelings of reward. But ultimately, it's this area, this very powerful area of the brain that is stimulated. Most of us have an inhibitory system that's intact that comes from our prefrontal cortex, the executive center of our brain, that tells us if we've had a drink or we've had a couple or we're using something else and we have to work the next day or we have to show up for an exam or whatever we need to go home to our spouse, we stop and we go home. But something happens in the brain of people who become deeply engaged in substances that gradually erodes that inhibitory system. The balance of go for it and time to stop is disrupted. Now, drug reward can be altered by a number of different things. We know that different classes of drugs have different types of rewards. So opioids, cocaine, marijuana, alcohol are all different. Opioids and tobacco have an intense enough reward or propensity for inducing brain changes that then create chronicity of use that's quite a bit higher than, say, marijuana and alcohol. So more people who use opioids recreationally will become, a greater percentage will become addicted than those who use alcohol or marijuana. It's not that there's no risk with those substances, but there's a greater risk with opioids. But another thing that we know is that the rapidity of the increase in blood level is associated with greater reward. So patients who misuse opioids will often, instead of swallowing them and waiting for absorption and them to get into eventually the blood and across the blood-brain barrier, will simply inject them, and it's much more rapid in onset. We know from the literature, for example, that cocaine, when it's snorted, can be associated with addiction, but many people, it's only when they freebase it and it gets really rapidly absorbed through the lungs into the circulation, then become addicted to it. So rapidity of increase in blood levels is important. The magnitude of the blood level, the dosage relative to the tolerance of the individual is important, and periodicity of effects. If there's an up and a down and up and a down, you're getting that high, and then perhaps in a physiologic dependent person going into withdrawal, and that seems to be more rewarding and reinforcing. And then there are specific receptor effects that have to do with biogenetic predisposition. Not everybody feels reward when they use opioids or other substances. Many people do, not everyone does. And pain may actually attenuate opioid reward, and there have been experimental studies subjecting people to experimental pain, giving them injections of opioids without pain and with pain, and measuring their liking, that suggests that under some circumstances pain can inhibit opioid reward. So this is just showing you in red IV administration, in blue IM and subcutaneous, and in yellow oral administration. You can see that the slope, which is the rapidity of onset, and the blood level relative to the same dose is greater with IV, which is why we see people converting medications. So drug exposure alone does not create addiction. Some people experience reward, some people experience no reward, but then that's filtered through the biopsychosocial context of the individual to create a pattern of drug use. And then, if they have a biogenetic predisposition and intense drug exposure, certain psychological and sociocultural factors that feed into this, we see the evolution of addiction in some individuals. We know that chronic inescapable stress, certainly in animal models, as well as in observational studies of humans, facilitate the evolution of addiction, as does an earlier history of trauma. And we see both, interestingly, both in the development of chronic pain and in the development of substance use disorders, a high proportion of individuals with adverse childhood events. So as somebody uses who is vulnerable to the disease of addiction, uses rewarding substances, the substances begin to engage different brain centers. Inhibitory controls are lost. Motivational drive to do well at work, to have important relationships, to have meaning in life become eroded, and meaning and value gets placed on feeding the limbic reward center and using more of the drug. Memory and learning is involved because we begin to associate the places we've used, the people we've used with, become triggers for using, and can often kindle feelings and cravings for use. Withdrawal may, physiologic dependence may develop, and withdrawal can drive people to continue using. So once addiction occurs, we see a variety of impacts on an individual's life. Functional disabilities, certainly in relationships, in work, in recreation, secondary physical problems, and often what we see in healthcare are the abscesses, the endocarditis, the hepatitis, the HIV, and the sequelae, or the gastritis and the hypertension might be associated with alcohol. And we often, sometimes, don't look behind that to see what's driving it. So we often are dealing with the anxiety, the depression, the physical sequelae of addiction. But in treating the whole person, we may come to see the substance use disorder. It's important to understand that addiction is a chronic disease, very much like other things. I mentioned diabetes, hypertension, and asthma. That was pointed out in 2000 by a really seminal paper looking at addiction as a chronic disease. Probably across the population, there's a 10% lifetime occurrence when you include alcohol, not including tobacco, which makes it somewhat higher. Biogenetic predisposition and drug use patterns contribute. Like other chronic diseases, there are remissions and exacerbations that can occur. We often refer to these differently, part of the carve-out of the disease of addiction. We talk about relapse and recovery more often, but really they're like other diabetes or other conditions, they're remissions and exacerbations. It's a life-threatening condition, so just treating the gastritis or the hypertension or the HIV, if we don't address the addiction, our patients are still at risk. So it's important that we identify it. Treatment involves lifestyle changes, counseling, pharmacologic interventions, not unlike treating cardiovascular disease. We don't just give people medications. We ask them to exercise. We ask them to diet. So in treating the disease of addiction, we may say you need to be in group counseling. You need to be less isolated. You need to go to meetings on a regular basis. We engage them in CBT, and we ask them to avoid drug use, and pharmacologic therapies can be very, very important in treatment. So when we engage people in meaningful care, not just one thing, but wraparound meaningful care, and we treat addiction, the outcomes are about the same as treatment of other diseases. We see that 40 to 60% of people are abstinent at 1 year, and that includes opioid addiction when we provide wraparound treatment that often includes pharmacologic care. And 15 to 30% may be using some, but not in a dependent manner. And that's similar to what we see in adherence to medications when we're treating hypertension, asthma, or diabetes, and in behavioral changes that we ask people to do for diabetes or cardiovascular disease. Compliance is less than 30%. So it's about the same. And adherence is lowest in people who have the less resources, less social support, less socioeconomic means, less transportation, lack of housing, and the other things that really challenge our patients, psychiatric comorbidities and others. So once we see that, we can embrace how we can be involved. So I mentioned the approaches are avoiding rewarding drugs, psychosocial interventions of various types. Group support is very, very important because addiction is often a disease of isolation and loss. So groups can be important, counseling, and then engaging people in health, in exercise, in managing stress and meaningful social networks, and then pharmacologic therapies that we'll talk about. So in the last 10 minutes, and then we'll have 5 minutes for discussion, I want to very quickly go over roles that we all have. So when we look at substance use disorders, we note that prevention is probably our most important. Identifying early and preventing people from becoming deeply involved in substances where they may come to harm, and preventing, when we can, the development of addiction. Treatment and intervention are important for a smaller percentage of our patients, and then certainly interventions such as, I thought I had 2 things there and I couldn't remember what the second one was, overdose intervention. So we'll talk about our roles, and one by one, which include optimizing pain treatment. That is a preventive measure. Best opioid practices when we use opioids. Screening, brief intervention, referral for treatment. Prescribing pharmacologic interventions for substance use disorders. Supporting recovery, and making naloxone available. So, very briefly, we used to think pain was a hardwired thing. The bigger the insult to the body, the more pain an individual would have. I'm not going through this whole slide, but just to point out that what we now know is there's a very complex neurobiology, that pain is a perception, and that the level of damage in the tissues really has a pretty poor correlation with what an individual experiences. There are examples of people who have massive injuries who require no morphine and have very little pain because of the context in which the pain has occurred, and there are other people who have very little tissue injury and a high level of pain. Some of that has to do with changes in the nervous system and the development of neuropathic pain, but suffice to say that pain is very complex, and the physiologic stimulus, whether it's tissue-related or neuropathic, is filtered through the entire psychosocial context of the individual, very similarly to that reward sensation, and can come out with a variable experience of pain. When we're treating pain, it looks very much like the chronic disease of addiction, persistent pain, because it has all the same sequelae: interference in function, secondary physical problems, mood disturbances, cognitive distortions. When we put these together, we have two reinforcing diseases. So it's very important when we're treating pain to identify substance use disorders and address them. And when we're treating substance use disorders, we need to aggressively address pain. We have many, many different approaches to pain treatment. I think of them in 4 categories. Medications, certainly, and many classes of medications, not just opioids. There are procedures, nerve blocks, steroid injections, joint injections of different times, stimulators, pumps, trigger point injections, many interventionalists, mostly done by pain specialists. And then we have psychobehavioral treatments and physical therapeutic type treatments that can be very powerful in treating chronic pain. Thinking of it as a chronic disease, as we do addiction, as we do cardiovascular disease, self-care is very, very important to chronic pain. Exercising, managing stress, a daily practice of relaxation or meditation can all be very, very important. So we emphasize those with the goal of not only reducing pain, but improving function. Just some evidence that there is a biologic basis to meditation and a biologic basis to distraction and being engaged. Pain centers do not light up when people are engaged in deep relaxation or in distraction, doing something that is meaningful and important to them. I work in an interdisciplinary pain treatment center, and it's just looking at, it's a 28-day bubble that people get into. And the only thing to take away from this is that it is possible taking people off of opioids at the same time you take people off of opioids, and in an optimal setting, engaging them in meditation, exercise, cognitive behavioral therapy. You can see pain interference with enjoyment of life go down, anxiety and depression go down. That's in a bubble. It's a lot harder to do it in communities, but there are many resources available, and if you treat patients with pain, I think it's important to engage with a cognitive behavioral psychologist who is interested in pain. Just know somebody who does that, or start groups. There are manuals for cognitive behavioral groups that can be implemented in general practices, and I can, if anyone wants to know some resources, I can suggest them. Mindfulness-based stress reduction is available in virtually all communities, even rural areas these days, or many anyway. And physical therapy, asking patients about a regular practice of exercise, starting slow and improving. So just to show that people can conquer pain in ideal settings, and we can work towards that in outpatient settings as well. Opioids, we know, are effective for pain in the short term, but we know the consequences: respiratory depression, overdoses, people become physiologically dependent. Many people, not all people, become tolerant. They stop working after a while. More and more, we're seeing evidence that some people actually develop worse pain associated with the use of opioids because of interactions of opioids in other parts of the nervous system and other processes that actually are pro-pain. And there are long-term endocrine changes, and people will misuse them. So opioids are indicated when the risk and benefit profile of opioids is superior to that of other interventions, and/or when somebody has severe pain and loss of function that is restored with the use of opioids and other things are not effective. But the more we learn about the long-term effects of opioids, I think what we're seeing is the indications for their use on a long-term basis are less than we had embraced a decade or two ago. CDC suggests that we use, these are the CDC guidelines in brief. Non-pharmacologic therapies are preferred for chronic pain, having both functional and pain-related goals, not just bringing the number down, but seeing that there are real changes and meaningful changes in somebody's life, discussing risks and benefits with the patient, using immediate release medications before we put people on long-acting medications that can accumulate and be more associated with harm initially in non-tolerant patients, using the lowest effective dose, and they suggest 50 milligram morphine equivalents as a point at which we should reassess what we're doing, And clearly, they feel that we need to justify anything above 90 milligrams of morphine. Clearly, there's some patients who will exceed those guidelines, and we don't need every single patient to be within those guidelines, but they are guidelines, and we need to consider them in our prescribing. Using a short course for acute pain when possible, 3 days being usual and greater than 7 being relatively rare. They suggest that we frequently evaluate the benefit and harms. All of these seem quite reasonable. That we try and mitigate risk. They suggest that for high-risk patients, we make naloxone available, and I would argue that wherever there are opioids, there probably should be naloxone, because you never know who is going to take that medication accidentally or purposefully and have harm. Check the PDMP, the Prescription Drug Monitoring Program, prior to starting, and either every prescription or no less than every 3 months. Doing urine drug testing on a regular basis and prior to starting, so you know if you're dealing with somebody who is using other substances, and you can adapt your prescribing to that. Avoiding concurrent benzodiazepines, and we saw the reasons for that earlier on. And then, very importantly, if somebody is having problems with opioids and misusing their opioids, don't just discharge them from practice. If they're revealing that they have a substance use disorder, we need to intensify our treatment of them, not abandon them. They'll just move on to somebody else. So referring them for evaluation for opioid use disorder and continuing to engage with them with other types of treatment. Substance use disorders are highly prevalent. We talked about an average of 1 in 10 people will have them. In hospitalized populations, they're much higher. Study after study has shown that about 1 in 4 to 1 in 5 to 1 in 4 patients who are in the hospital with medical disorders has a substance use disorder. And in trauma populations, study after study suggests about 50% of people with major trauma. So when we see patients in these settings, we need to have a high concern and rule out a substance use disorder. Most of us don't, I'm not going to go through this whole study, but suffice to say that a study that was done, a reputable study that was done, that presented classic heavy alcohol use, hypertension, gastritis, sleep disturbance, irritability, depression. 93% of primary care doctors didn't put alcohol use in the top 5 of their diagnoses. So it's not something we always have antenna for. We're so naturally focused on healing the physical ills, but it's really important that we all look behind. So screening on a routine basis, giving patients feedback on their use and referring them for a higher level of evaluation or treatment is important. When we have recovering patients, it's really important that we support that recovery. It's a relapsing condition. So somebody who's recovering from alcoholism, or they used to have an opioid, or they've opioid use disorder, on or off medications, or other things, asking about it, having it on the problem list. Asking about it at every appointment, or if they're in it once a week, probably once a month, whatever. But at reasonable interviews, so we can support them. What are they doing to support that recovery? It doesn't just happen. Checking on co-occurring issues, anxiety, depression, sleep disturbances, things that can lead people to use substances. Reviewing their medications if they're using something for naltrexone or camprosate or other things for alcoholism, or naltrexone, buprenorphine, or methadone for pain. Asking about targeted exam, looking for signs of use, and then really giving them feedback and recommendations. I'm going to end with this group. Pharmacologic therapies for opioid use disorders. 2 of these 3 are available to anybody who chooses to become waivered. Actually, naltrexone, you don't need a waiver in order to do. So the idea behind opioid agonist therapy is when people are using opioids to get high, they become physiologically dependent, they're using them erratically, spiking and withdrawing. When we give them methadone or buprenorphine, we give them a stable dose that keeps them in that area of homeostasis when we overlap the doses. So they're not in withdrawal, they're not craving, they're not high, they can re-engage in their lives. Methadone treatment has to be done in a federally licensed center. Methadone, when it's diverted because of its unpredictable half-life, when it's misused, it can be very life-threatening, so it's highly controlled when used to treat addiction. It may prolong the cardiac QTc interval and be associated when combined with some other medications with cardiac arrhythmias, but that's rare in methadone treatment settings. It can occur, so it's something to keep in mind. So it's usually dispensed, it's not given in a prescription, and over time, patients can get up to 1 week of take-home. It's a good option for some patients, and we need diverse options for people who need pharmacologic therapies. You're probably aware of buprenorphine, often known as Suboxone, but there are many different trade names of buprenorphine out there now. It's a partial mu agonist. It binds to mu opioid receptors. It binds to opioid receptors very, very tightly, but it doesn't fully turn them on. It turns them on fully for pain, to block craving, but it seems to have less reward and less respiratory depression than many other opioids. And so it's somewhat safer. Overdoses are possible, particularly used IV and particularly when combined with benzodiazepines, however. It has a long half-life and it blocks withdrawal for 1 to 3 days, depending upon the dose. It can be anyone who is a physician, a nurse practitioner, or a PA can get a waiver to prescribe this, and I would encourage all of you to do that. 8 hours of training for MDs, 24 for ARMPs and PAs. And I heard yesterday from somebody at one of the National Nursing Associations at a meeting that 6,000 nurse practitioners have become waivered since January. That's fabulous. Yes. I suspected that when it became available to nurses and PAs that we would see a huge increase in certified people. So thank you, those of you who are nurse practitioners who are doing that. It's prescribed, not dispensed, so it gives much more flexibility to individuals who use it. And the studies are that without opioid agonist therapy, across the general population, 90 to 95% of people relapse within months of stopping opioid misuse. They relapse to opioid misuse. With opioid agonist therapy, about 66% are retained in treatment at 1 year. 50% of those in treatment may have some drug use, but it's not dependent, it's not interfering in life, and it's usually not opioids, it's something else. So decreased mortality, decreased criminal involvement, decreased health comorbidities, increased employment, increased quality of life. So this is a disease where we make incremental changes, but we can all make a huge difference. This is not just by prescribing pharmacologic therapies. It isn't substituting one addiction for another. Physiologic dependence may be present, but if the functional criteria aren't there and somebody's engaged in their lives, physiologic dependence, it's not the disease of addiction operative. They can restore their lives. How long should people be on pharmacologic therapy? As long as it's necessary for a high quality of life. For some people, that'll be several months, a year, 18 months. For some people, it'll be their whole lives. It's like diabetes. Diet and exercise, you may be able to get off your insulin. You may not be able to get off your insulin. It's okay. We do what we need to do. Okay, naltrexone is available. You don't, and there is accruing evidence. Naltrexone is opioid blocker. It's not an opioid, so it binds to the receptor. It doesn't activate it. It reduces craving. It reduces the high if people use drugs, so it stops that reinforcement. There's increasing evidence of its efficacy. I was told yesterday at a meeting in Washington, met a lot of interesting people doing interesting work. Somebody told me of a recent large study head-to-head with buprenorphine. He felt the outcomes were very similar. That remains to be seen. It may or may not have the effects on craving that buprenorphine does and blocking craving. But it's a tool that's available. Depot injections lasting 30 days can be used. Okay, so I'm going to really end there. You're aware of naloxone. I would suggest co-prescribing. There are a number of treatments, including opioid antibodies, implanted sensors for O2 and CO2 sensors that will automatically inject naloxone in people who are in the course of an overdose, new opioids on the horizon that don't have reward effects. And I'm going to stop right there and suggest that Remember, multidimensional approach to pain. Best practices when we do use opioids: screen, referral to brief intervention, support recovery. Get involved if you can with pharmacologic therapies and naloxone for overdoses. There's so many ways that we can be helpful in really addressing this epidemic. Thank you so much.